Hi everyone, this is Mark Nisly here. I'm presenting on reimbursement, billing, and coding. This is a nurse practitioner issue presentation. An introduction here, I just want to kind of go over some of the reasons why I thought this issue was important, why I was curious about it, and some of the things I learned. The first thing I want to mention is the laws can be murky, they're outdated, maybe they're restricted to nurse practitioners or nurse practice acts. Don't give a lot of clarity. In Pennsylvania, we're also relatively restricted here, and it's unclear what our sometimes what we can do with billing. And then, of course, the federal law does trump state practice acts in the areas where it applies. There's this incident to clause, which I'll actually end up spending quite a bit of my presentation talking about because it's so influential in this topic of billing. Another reason I wanted to address this was there was concern for running afoul of anti-kickback statutes, so that's relatively intertwined with the incident 2 section, so I'll cover that as well. And then when I was trying to pick this topic, I actually did a Facebook post here, you can see, and I asked which topic would be most interesting. And comment there, the top one there by one of my friends said that she felt like she didn't have enough education on this, so I thought it was really interesting. It's something that's really opaque to me as a bedside nurse. I really haven't had much experience or exposure to the billing and coding side, so it feels like it's an important topic to address. And then toward the end, I want to talk a little bit about possible future direction or advocacy, things that could be done, and then also like a few tips for how to bill appropriately. Alright, so first I want to talk about the incident 2 clause because it just really influences so much of how billing works for nurse practitioners. Okay, so first some background on Medicare and the incident 2 clause. So Medicare is a federally funded program. Normally they would pay 80% of physician services that are billed, and the patient would be responsible for the other 20%. So prior to the Balanced Budget Act of 1997, the advanced practice providers, including nurse practitioners, weren't even allowed to bill to Medicare. So since 1997, they have been able to bill directly to Medicare, but only at 85% of the allowable amount for the physician fee schedule. So there is an incident 2 clause which would allow advanced practice providers to bill for the full amount of the physician fee schedule as long as all the requirements are met for the incident 2 clause. So what this basically assumes is that the services NP provides are part of the physician's care package. Alright, first I want to summarize the incident 2 criteria. Basically, this is just making sure that the services that the NP would be billing for are truly under the supervision of the doctor. The first two kind of go together in that the services provided and the type of services need to be appropriate to the setting and the physician's expertise and so forth. The next one there is that the services need to be under the direct personal supervision of the physician. This is not interpreted to mean that they need to be in the same room, but they need to be kind of in the same building or suite, and they would need to be readily available for assistance. Additionally, the initial service needs to be provided by a physician, and they need to have subsequent services of sufficient frequency to demonstrate they're actively participating in the care of this patient or service. And then also very interesting for me, since I plan to work in a hospital setting, is that Medicare would require the hospitalized patients to be under the care of a physician. So I'll go over some of the implications of these criteria here on the next slide. So first, I mean, kind of a no-brainer, and I discussed this, but you have to literally be in the same physical location as the person who's supervising you. So this could be interesting, depends how you have your practice set up. definitely need to have the provider on site and on this during the same hours that you would be there. Something else that's really pertinent is they cannot use, or nurse practitioners cannot use this incident to clause when providing initial service, or maybe they're doing a follow-up and they notice that there's a new issue has arisen. So they cannot use the incident to clause when practicing more independently. So there are three things that they could do. You could have a physician come and evaluate the new issue part, and then you could do the incident to clause to bill. You could just bill it as an NP visit under the nurse practitioner's national provider identity number. Or you could only bill for the previous condition. So those are all perfect options for what to do if you would have a new issue arise while seeing a patient. This second half of implications of incident 2 for hospitalized patients is especially interesting to me because this is the care setting I expect to be working in. And especially this first line here, that realizing that nurse practitioners can't practice their full autonomy even if supported by state law when they're caring for hospitalized patients because of the Medicare statutes expecting that a provider, or a physician being in charge of all Medicare patients. So basically that means that nurse practitioner needs to bill under their own national provider ID unless there truly is a physician face-to-face evaluation on the same calendar day. So a couple more concerns with that is just to make sure that you're not double billing. So for example, if a physician and nurse practitioner would both see a patient on the same calendar day, only one could submit a bill. And then another consideration is if you would have some kind of global fee, like say you're having a cholecystectomy for a set price, you can't charge for that global fee and then also the nurse practitioner bill separately for services. And then one final comment that was new for me was, since this class, is to be aware of the potential for anti-kickback infringement, such as Stark Law. And that would be if the nurse practitioner and the supervising physician are not part of the same group. For example, if the nurse practitioner would be working for the hospital and the physician would be in private practice seeing the same patient, then it could be construed as benefits to the provider or some kind of compensation to them by having the nurse practitioner see his patients. So that's important to remember as well. So as you might suppose, this incident 2 clause is broadly opposed by nurse practitioners and physicians alike and other advocacy groups. And there's a variety of reasons. First of all, it's old. It really doesn't reflect our composition of current providers and our reality right now, where we're heavily reliant on advanced practice providers to keep up with demand for healthcare. Something else that I think is really interesting or important is that we have increasing evidence that nurse practitioners and other advanced care providers are just as good as physicians at providing good outcomes and being cost effective. And I listed here a study by Benning et al. In 1999. I'm not sure this is a sentinel study, but that did mark, well, let's say, so it occurred in Great Britain about 10 years into allowing nurse practitioners to be primary care providers, and the authors really wanted to know, does this make sense? And their data found that it does. The outcomes really are as good. So I think that's an important consideration. It also, the Incident 2 clause contradicts other statutes, such as the Affordable Care Act. It would not support the full autonomy of nurse practitioners, so again, that's kind of like contradicting other statutes. And this one's kind of an ethical one in that it decreases access to health care and outcomes because it's limiting service. One of the current considerations is a provider that, or a patient that's seeing, has a diabetic foot ulcer, needs to have certain kinds of equipment ordered only by a physician. So that limits access to diabetic patients for care. And then the last one that I think is also really important is this was put forward by the MedPAC Commission to Congress, and they just talked about how by requiring the Incident to clause, then a lot of the services rendered are being kind of, like, we don't have a lot of data transparency there. Like, we don't really know what's going on, where's the money going, what are the outcomes like, and things like that. So it really doesn't make sense to continue to bill under a physician service if you're doing most of the work. So how to reform this? Yeah, it seems like it's going to be difficult, even though there is broad support. I listed the MedPAC Commission to Congress is already recommending this. Interestingly, the same commission also recommended refinement of Medicare specialty designations in recognition of more advanced practice providers going to specialty fields. One thing that's not clear is there a consensus to improve autonomy at federal level for nurse practitioner billing? Yeah, I don't know if there's any real chance of moving that dial anytime soon. So a good question now is to try to figure out what can we do to move legislation forward. What advocacy things can nurse practitioners do? So I selected several recommendations from the AANP. First is kind of obvious. You just contact a congressional member. It can be call, possibly in person, most likely be either automated system for providing input. And again, the key thing would be to use professional and clear language. If they don't know what you're asking for, then it's difficult to make a change. The ANP also recommends specifically requesting, I think they call it supporting or congressional support for specific bills that would be on tap. So there's two listed here. One would be to allow Social Security to allow nurse practitioners to certify home health eligibility, and the other one would be to allow nurse practitioners to care for patients in ACOs. And interestingly, they also suggested we continue to maintain contact in between, even when there's no specific bills on the table. So the last section here is just briefly discuss appropriate billing for nurse practitioners. One of the main reasons I wanted to address this is because it seems like it's quite a challenge for new nurse practitioners. Working as a bedside nurse, and this is something that's really opaque to me. I really don't have much exposure to billing at all or coding. So part of the reason to pay attention to this is overbilling and underbilling. If you overbill, especially if coupled with inadequate documentation, it really exposes the practice to sanction by CMS. And then also, if a lot of bills would come back or be rejected because of inadequate documentation, it could increase the cost to the patients and also to the practice. Underbilling is also not ideal, as it could put financial strain on the practice and might actually decrease the nurse practitioner's value to the organization. So the solution would be to just make sure you understand the billing and coding requirements to select the correct CPT and to bill correctly. And if you understand the documentation that is required, it shouldn't be too difficult to select or to make sure you're documenting the right thing and then to select the correct code. So this video here I thought was very helpful. It just gives kind of a summary or a crash course to how to start billing if you're a new practitioner. It's beyond the scope of this presentation to review those details, but in case somebody is interested in further information. And finally, I have my references. Thank you for listening.